Hey, everybody. Welcome back to the Healthy, Wealthy, and Smart podcast. I am your host, Dr. Karen Litzy, owner of Karen Litzy Physical Therapy, located in the heart of New York City. And on today's episode, we are going to talk about paths within care delivery and how they have, I think, drastically changed over the last couple of years. And so to help us, I'm really happy to have fellow PT, Dr. Jackleen Samuel, on the podcast today. She is the CEO and president of Resilient Healthcare out of Plano, Texas, and a serial entrepreneur deeply passionate about disrupting traditional healthcare delivery. So, Dr. Samuel, Jackleen, welcome to the podcast. I'm always thrilled to talk to a fellow PT. So welcome.
Thank you, Karen. I was thrilled to be on a podcast with fellow PT.
Yay. All right. So let's talk before we get into the healthcare delivery of it all. Can you talk a little bit more about your background and how you got to where you are today with Resilient Healthcare?
So I am a physical therapist. I worked in all different settings of care. I went to PT school actually because I wanted to treat athletes. I played soccer my whole life. I ran track. I wanted to treat athletes. And when I graduated, I did treat in the, outpatient space, the sports rehab space. My first private practice was a lot of athletes, especially runners. I kind of became the physical therapist for runners in my little area. And my dad had a stroke. And as things happen in your personal life, you start to really shift. And I was working in home health really just as a way to see patients on the weekend, make a little bit extra money, and realize there's this huge gap in care for patients who are homebound, really chronically ill, and they're spending so much time in the hospital. And a lot of it could have been delivered to them at home, my dad included. And I grew up one of five, very family oriented, and I was just like, this is crazy. This is such a burden on families. Once something happens or disease progresses to a certain point, rather than delivering the care to patients, we just say, go back to the hospital, go back to the hospital. And they spend so much time there. And so I wanted to I wanted to bridge that gap. And that was really the beginning of Resilient.
Yeah, and as almost everyone will say, the last place you want to be when you're sick is in a hospital.
Yeah.
It's like because it's you like I understand from like a life-saving standpoint, yes, you want to be there. But what you're speaking about are these sort of people with more chronic conditions where, like you said, they can definitely be taken care of at home. And when you go to a hospital, what happens? The biggest complaint is I can't sleep.
The beeping.
The beeping. I'm getting woken up in the middle of the night. They're coming in at all hours. I don't like the food. I can't get up and move around. I can't, there's so many restrictions.
Yeah, and I would say, there's a push for hospitals to be more hospitable, but at the end of the day, we say like these patients are sick enough to be in the hospital, but stable enough that we can really treat them at home.
Right, right. And so talk about your um, transition from this really full-time patient care into a non-clinical role.
So I am a crazy person because I was running my private practice and I was still treating, and I had started this staffing agency to treat in the home. And so I was doing both simultaneously and really building out. And initially, we were a palliative care vision. So not hospice, not home health, but this in between for chronic care illness that we can treat patients, rehabilitate patients, but also understand that they are in a chronic state.
Mm-hmm.
And so I did both at the same time. And
That sounds about right for PT.
yeah, yeah. And I also had a kid in between. So and then I really just started at my home business was picking up, and I started doing less in the clinic and more in patients' homes. And as that transition goes on, you start focusing, okay, if I really want to fix this, like I'm one PT with a bunch of other PTs trying to fix this palliative care at home kind of model in the middle of a huge healthcare industry. And really, it's not just palliative care. We're really trying to fix access to care, and we're trying to fix patients being able to navigate such a complex system, but being home and like reducing the burden on families. And so I just at one point I had to take the leap of faith, and Resilient became my one and only.
Mm-hmm.
Yeah.
And how has Resilient changed from its origins to where you are now?
So when we started Resilient, we were providers. We pulled in, and that was I'm a PT, so provider by trade, and so
Mm-hmm.
pulled in physicians and palliative care physicians and internists, and then we pulled in nursing and we pulled in physical therapists, and we toured all these hospitals in our area and asked them questions. Why do you have a high readmission rate? What are patients coming back for? What can we recreate in the home? And then had essentially a roundtable of every discipline that would have been in the hospital. If we're going to recreate the hospital, let's get every discipline around the table and say, what could you do if you were in the patient's home? And so when we started, we were really clinical path oriented in a sense, and
Mm-hmm.
physician oriented, and also physician driven, I would say, and licensed that way. So we were a physician house call group. And
Okay.
as we transitioned into more of a management operations tech enabled platform for hospitals, that that really came by ways of the pandemic and a lot of delivery changes happening in the industry. So during the pandemic, we were worried about our ALS patients going to the hospital. And so
Sure.
we started managing those patients at home. And so testing them for COVID, doing x-rays at home of their lungs, getting IV infusions in place if they needed it. And hospitals took notice. And then we started doing risk management for hospitals. So in Texas, elective surgeries were shut down for some time.
Mm-hmm.
We were like, what if we test these patients before they go in for a knee replacement? Just because it's elective doesn't mean that it is not a burden on these patients. If you have
It's a huge burden.
yeah, and if you have
Yeah.
like, if you're about to get a knee replacement on Monday and now you can't get it forevermore, and you've been dealing with this for the last 10 years, that's still tough on you. So we started testing and clearing patients for COVID. And then if they were positive, treat them. And if they weren't, clear them for surgery in the home. So they never
Mm.
entered the hospital until.
Right. So they didn't have to make the extra trip to the hospital for the pre-surgical testing,
Correct.
blood work, things like that. That can all be done at home. So then they show up the day of surgery and they're in.
Yes, and they've already
Yeah.
been cleared. They don't have COVID. They're not going
Yeah.
to put it in your hospital. And so for us, that was our first really eye opener of like, we should be working with hospitals. We
Mm-hmm.
should be extending their care into the community. And then during the pandemic, of course, Medicare approved the hospital at home program. Dr. Leff, who is a advisor to me, spearheaded that with CMS. And so we ended up partnering with Medical City Hospitals, which is HCA's North Texas division. And we launched the first acute care at home program in collaboration with that hospital during the pandemic in the Texas region. And it was great. I mean, it was great to see patients getting treated at home at an acute level, working with hospitals, being integrated with their policies, their procedures. We provided all in-home, in community type of modeling. And so the pandemic really, really shifted in how we were thinking of the entire industry. And of course, there's been so much regulation changes too. Hospital at home became approved by Medicare. We're hoping that there's an extension this year, which it looks likely. And then telemedicine had a lot more
Mm-hmm.
facilities and all of that. So we really then transitioned to, we want to touch as many lives as possible, and we want to make this an option for patients as fast as possible. And so let's work with hospitals who have a patient caseload, who have an infrastructure that we can build on. Let's be the bolt on for these hospitals and start touching lives quicker.
And when you say acute care at home, can you give the listeners an idea of what that looks like from a practical standpoint? So let's say I am one of your patients. Who is coming to my house? What is happening? How does that work?
So we do a number of things. One of them is acute care at home. So say that you are the patient. You went into the emergency room and you saw the ER doctor, and the doctor said, you have a UTI, you need to be admitted. But you're stable enough that we can treat you at home. And so you are qualified to be admitted, go to upstairs to the med surg floor, get your, IV infusion for
Mhm.
etc. Rather than that, you agree to, oh, I'd rather just be treated at home. Of course, if you can bring it to me, you
Of
go home.
course.
And then we manage that whole process. So you get at least 2 nursing visits a day. If your order is a 3 time a day IV, you're actually getting 3 nurses a day. If the hospitalist ordered physical therapy, you're getting physical therapy every day. But you're being treated at home as if you were in the hospital.
Got it.
And yeah, and so meal delivery, if you need the meals, they'll be delivered to the home, medication to the home, administrating the meds to the home. And then you have 24/7 monitoring as well. And so we partner with a device that does continuous monitoring. And so we have in real time insight on patients' vitals every second of the day if we wanted to set it up like that. We have the ability of doing a 12 lead ECG that's FDA approved without sending you back to the hospital. And so you're really getting a full hospital level care. Now, acute care at home is usually a 2-3 day length of stay,
Mm-hmm.
as in you went to the ER, you were very sick, they wanted to admit you, and you would have stayed in the hospital for 3 days. Instead, we do it at home. So you're only in the hospital for that ER admission.
Got it. And so the people coming to the home can be nurses, physicians, physical therapists.
Yes. So nurses, physical therapists, physicians can round on you virtually. So you get a
Okay.
tablet. That tablet is your gateway for your vitals. And so we have a central nurse that can see your vitals virtually. That's the person
Mm-hmm.
you call if you have any questions. That's the person who will call you if they see your vitals are not stable.
Mm-hmm.
And every day the physician will round on you on that platform. So you're literally doing a FaceTime with physicians every day, and then you're getting nurses in there in person.
Got it. And what has been the feedback from patients on this?
Well, the research says there's like 97% patient approval, like patients would prefer this.
Mm-hmm.
Our joint venture with CHC is really on the merit that this is a consumer-driven model. People will prefer to be treated at home, especially if it's an option. But on a more anecdotal, like if we had one patient who was like, yeah, I want to go home. I want to be with my cat while I'm recovering. Who's going to take care of my cat while I'm here for 3 days?
Mm-hmm.
And so, yeah, people want to be home. And if you could
Yeah.
bring it to them, then absolutely.
Yeah, no, that makes perfect sense. And how does that work? Sorry, I have so many questions. Um,
It's
so
fine. I like it.
so how does that work from a business standpoint? So how does resilient healthcare, do they get a lump sum from the hospital? Are they billing? How does that work?
So we changed our model multiple times, and then over the last maybe 2 years, we've standardized it. So we've tried the pay us per diem per day. We've tried and it just we want to be incentivized by what's best for the system, and so we've
Mm-hmm.
changed our model. We help stand these programs up with hospitals. So we contract with hospitals. We stand these programs up for hospitals. Hospitals pay us technology fees for the certain technologies they choose. Some of that technology is actually licensed through third parties that we think are the best in the industry. We put them all together, and this is what you need to provide this level of service. They pay us to manage the program, and then as needed to staff the program. Some hospitals are already short on staff and they need help staffing the community-based program, so they'll pay
Mm-hmm.
us. So really it's a combination of like software, technology, management, operations, but at the end of the day, we're selling into hospitals.
Got it. And so when that patient is billed, they're billed through the hospital system.
Yeah, this is a
Yeah,
hospital patient. This is we're
got it.
enabling the hospital to provide the care. All the clinicians are credentialed by the hospital. All the clinicians are onboarded by the hospital. So when the physical therapist shows up at the patient's house, they represent that hospital. They've been credentialed by that hospital.
Got it.
All nine
Got
yards.
it. Got it. But because when it first started, you were supplying the
Correct.
staff. Yeah. So this sounds like a lot less of a headache for you.
Oh yeah. Oh
I
yeah.
mean, I'm going out on a limb here, but I feel like it's less of a headache for you.
Well, welcome to healthcare. If you are not
Yeah,
a huge hospital enterprise, it's a lot harder for you to get the right kind of contract.
100%.
It just doesn't happen. You don't have the leverage to negotiate
Right.
with payers, nor could you scale fast enough, to be quite honest. And so
Mhm.
for us, we made the decision of like these hospitals are in place. They want to enter the community. Let's just help them enter the community.
Got it. So that's the gap you saw, and you felt that it's better if we're coming in from a tech management position than a staffing position in order to fulfill the needs of the community.
Yes, but I would say even more so than a provider, like than a NPI.
Yeah,
This is our, also there's all the regulation around that and
right.
so yes, to scale, we want to, we're experts in program design, is what I like to say.
Mm-hmm. Mm-hmm. Got it. Got it. So just to recap, patient, they go to the ER, they say, no, I want to come home. The ER physician or hospitalist will then say, this is your plan of care as I
Mhm.
see it. They send that plan of care to you?
They send
How
it
does that work?
to resilient. Yeah, so there's a handoff. So the hospital has their own EMR system they can document in. They will order, this is the plan of care. The patient needs, I don't know, two IVs a day. They need
Right.
PT, they need whatever. They'll order everything in there. And then our TM will make sure that all of that is ordered. A lot of that is getting automated now.
Mm-hmm.
And so if they need this one IV, then they'll get that IV mailed to the house or the whatever the workflow is. Before we even go live with a hospital, we spend maybe about 2 to 3 months
Mm-hmm.
on workflows with that
Yeah.
hospital. And
Yeah.
I mean, every hospital is a little bit different, especially like you're in New York City. New York City is going to be a very different workflow than El Campo, Texas.
Sure.
Rural America, different than urban. So
Mm-hmm.
so we have those workflows in place. Medicare actually walks through the workflows with the hospital before they even approve the hospital to provide
I
hospital.
see.
Yeah, and so by the time the patient actually gets home, that workflow is already identified. And so, yes, you go home, they can document in their EMR in the hospital, it'll get carried over, we'll execute on the orders from the physician, the nurse. In some areas, we have nurse practitioners who go to the home, so the nurse
Mm.
practitioner will go to the home and she'll do a handoff with the hospitalist, like, okay, I'm in the home, I see your orders, this is the things that you didn't take into consideration,
Mm-hmm.
XYZ, because now I'm in the home and I see it.
Sure.
And
Sure.
then they'll have nursing visits in there. They'll all communicate on the same platform, and then PT as ordered, and
Mm-hmm.
discharge planning is the same as it goes in the hospital. So
Mm-hmm. Mm-hmm. Okay. I think I got it. I mean, it sounds like, it's what I do. I go to the home because I want to make the lives of people a little bit easier,
yeah.
right? And
So
it
what kind
sounds
of
like that's
patients
what
do
you're
you see
doing.
in the home?
What's that?
What kind of patients do you see in the home?
I do see a lot of kids and a lot of teenagers, mainly orthopedic injuries. I have a couple of people with more chronic, like neurological conditions as well, where it's hard for them to go to an outpatient physical therapy office,
Yeah.
and for a lot of the kids and teenagers I see, they're so overscheduled. It's hard
Yes.
for their parents to be like, okay, now I have to take them here and after this, and it's just very difficult. So those are the main kind of people that I'm seeing are people who uh, it's difficult,
Yeah.
and so it's a lot easier for them to maybe have their online tutoring and then I show up right after.
Yeah. No, absolutely. So like when I had my private practice, I would go out and I would see the majority, like a number of my patients wherever they wanted, in a
Yeah.
sense. So
Yeah.
and runners, so I would meet them at the track, and it is
Yep.
just like I can actually see them running on the track, and I'm like, oh, this is different than when you're running in the treadmill in the clinic,
100%. Yeah.
And so that was really the basis of my career prior to me embarking on this whole like not just physical therapy. Why don't we bring
Mm-hmm.
physician care and pharmacy and
Yeah. Yeah. Yeah.
well, you name it. But it's the same merit. Like if we can order something on Amazon and can get here in 3 hours, you're telling me I can't communicate with a clinician to come to the house? It's wild. How did
Right.
healthcare become the least priority for
Right.
efficiency?
Well,
So
and I think it's because it's obviously incredibly regulated, which, I understand it certainly has to be. But I think it's also the rigidity of the system. It's like this is how it's always been done.
yes.
And so moving forward, this is how we have to do it. And I think COVID changed that, especially for Medicare. Because
Absolutely.
man,
Until the
Medicare was
pandemic
doing
hit.
none of that.
And once the pandemic hit, they're like, oh, we can't survive like this. But
Right.
yeah. So for our programs with hospitals, we do the acute care at home program. We also do a lot of extending their other services into the community, whether it's primary care at home, physical therapy at home on an
Mm-hmm.
outpatient basis. Let's get your clinicians out of the clinic and into the community. And so
Mm-hmm.
um, honestly, that's the bigger opportunity. And I think that's the biggest change in patients too, is when
Yeah.
you like build the relationship with them on an outpatient basis in their homes.
Yeah. There's no question. And, the thing that always still and I've been doing this for a long time, but that amazes me is that when I go to someone's house and you get to see how they live, because when they come to your clinic for 1 hour twice a week, right? And they say, "Oh yeah, no, I don't have throw rugs, or I don't, I've got plenty of room. Yeah, no, I can get a shower chair that'll fit." Or we've got, and then you go to their home and you're like, "What?"
Yeah, and I've been to
Like
those.
I need to move furniture. Like I have spent time on my hands and knees tacking down carpets and, moving furniture out of the way. Or you have surgery coming up. Let me get into your house before your surgery. Let me see what we're working with here.
It's a
Because
different environment. And
yeah,
also you're entering their comfort zone.
that's
And
right.
it's very different. And I mean, you see patients in their homes.
Yeah.
It is, you get such a different reaction from them. They're comfortable
Yeah.
in their environment and you're respectful of that. And
Of course. And I think you get a little more vulnerability on their part. They're more willing to share things. And you get to, because sometimes I'd say to people,
sometimes too
"Oh,
much,
what's that?"
sometimes too much.
Well, yeah, but that's okay.
Just kidding.
But, sometimes like I'll say, "Oh, do you have to do any stairs?" "No, I have an elevator in my apartment." "Okay, cool." So then I go to their home and there's like 3 steps to get in. Then there's 4 more steps to get in. Oh, and the elevator goes out a lot. And,
Yeah.
so it's like people don't,
The,
they just don't think of it if it's not in front of them.
the thing that boggles my, like, home health has been around forever. It's been around
I
for
mean,
years and years. And
yeah,
still to this day, people don't realize that you can get care at home. And
yeah,
granted, home health has a lot of homebound regulations and all of that wrapped around. It's a little bit more
yeah,
difficult to manage on the regulatory side. But it is crazy how much of a disconnect there is with traditional home health that has been around for at least, I don't know, 50, 80 years since and hospital systems or and then and
hmm,
outpatient clinics. And there's like no communication in between the whole patient's continuum of care. Or there is, you got to call someone, you got to call the office, you got to be on hold,
hmm,
figure it out. And then unfortunately, the response is usually like, well, whatever, we're just going to call 911.
yeah, yeah,
That's what we're trying to avoid by connecting all of these missing puzzle pieces. And we just so happen to say if we partner with hospitals, we can enter a bigger network, but then
sure.
connect all of our community providers within that network. And that's what we've been doing. So when we enter new markets, especially in the rural communities, we will target all of the providers in that community and try to get them credentialed through that hospital so we can build a good continuum of care for that neighborhood, for that
Got
community.
it. Got it. Yeah, that makes sense. And so let's say we'll take our profession, physical therapy. So if you go into a community and there is an outpatient physical therapy office there, will you contact them to see if they want to be involved, or are you,
We
or you know what I mean? Am I making
Yeah, we
sense?
have, and we've like we so say we walk into a hospital and they have an outpatient PT clinic on the first floor or whatever.
Yeah.
We will make sure that prior to us going live, we are working with that clinic so that they know that this is an
Mm-hmm.
option of care that and not surprisingly, they'll say, "Oh, I have this one patient who shows up once a month instead of 3 times a week because they just don't feel like coming because it's harder to
Always.
get
Yeah,
a
it's
ride."
hard.
But they're
Mm-hmm.
not homebound, so I can't refer them to home health. And so I just need help with this compliance. And so we extend their care into the community rather than, rather
Yeah,
than saying,
totally.
well, they don't qualify for home health and they,
Too bad for them.
yeah, give them a home exercise program. They're not
Yeah.
gonna do it. So
Yeah, yeah, yeah. Oh, yeah, that makes a lot of sense. So that it's more than just the traditional home health patient. It may be people who, like you said, maybe they can't get a ride.
Or maybe they can't afford the gas because it's 50
Yeah,
minutes away.
yeah, exactly, exactly. So those people are also continuing their care.
Yeah.
Yeah, that makes a lot of sense. What's as you're going through this process of um kind of creating resilient and then pivoting a little bit and moving into different areas, what is something that really surprised you the most?
Oh, well, initially, what surprised me the most was how it's very difficult to work with payers if you're not a big conglomerate.
Yeah.
When you go to grad school and you come out and you think like, oh, I'm a licensed PT now. If I start my own practice, then I can just, all I need to do is get volume and I treat my patients and I make as much as that clinic down the street. Like, no,
No.
surprise, that's not how it works. So that was a huge one. The push to get systems to change, like the amount of effort it takes to get, like you saying this is better for the patient is not enough, unfortunately. And it also depends on who you're talking to. Like
Right.
hospitals care if it's better for the patient. They also care that they keep their doors open.
They got to make money.
Yeah,
It's
exactly.
the money.
Correct. So like the way, and you start learning how money moves in healthcare and you start following that dollar. So like it either goes all the way up to the corporations or on commercial plans, or it's going all the way up to the government on federal plans.
Yeah.
And just like how did we get this convoluted? Like how did it get so messy that the patients don't even like, it's the only industry where when you order something, you don't know how much it's going to cost you. Like the only one. Like yes, we know that we have a copay, we know our co-insurance, we know we
Hmm.
have a max out of pocket, but then you find out that your max out of pocket is different if they're in network or out of network, and you don't know if this provider's in network or out of network, and then you get this bill and then they build you and then they build you, and then it is literally the only industry where you're like, my knee hurts, I want to go get a PT evaluation, and you should know how much that's going to cost you. But of course, it
Right.
changes depending on your payer, and you can't just. So that whole the industry is so broken with transparency on cost, and I know that there are laws around price
The
transparency.
the No Surprises
I
Act.
get it, but just because providers are putting what they bill on their website does not mean that the patient knows what they're going to pay, because 9 times out of 10, they think the insurance is paying for it.
Yeah.
And the insurance says, nope, sorry, this doesn't qualify under your whatever. It's going 100% to your deductible or whatever, And so
Yeah.
that was a huge surprise for me. Like entering the industry, that was a huge surprise for me.
Yeah.
On the flip side, it's been a huge surprise for me how people are engaging with the idea of hospital at home.
Hmm.
Like it's sexy right now. It's on New York Times. It was on the news. It was on like
Yeah.
people are, oh, we can, and you would think like it's common sense healthcare. You're sick.
Well, it's how healthcare used to be.
Correct. It's how it
Like
started.
the
Hospitals.
neighborhood doctor would come to your home and he would do a house call. That's how it was.
And our generation is the first generation that has access to all this technology.
Hmm.
Why are we not implementing it in healthcare the way that we implement it in consumer goods? And so, I can
Hmm.
go on all day about this, but all of these were surprising. But I would say we've been getting really, really good traction with hospitals, especially ones who want to enter the at-home or community model.
Hmm.
It's not always a financial incentive. It's some of it is just like, I think this is better for our community. And so that's been interesting to see.
Yeah. Yeah. Well, that's lovely. Um, that's
Little
that sounds lovely. Well, as we kind of start to wrap things up, what what are your big takeaways? What do you want the listeners to take away from our discussion today?
If you have a good idea to shift healthcare to a more positive outlook in the US or globally, um, Do it. Take the risk. And like if you don't, nobody else will. So just do it. This industry needs the brightest minds, whether it's young minds, older minds. We need the brightest minds to keep pushing the envelope forward in a safe and efficient way that improves access to care for patients.
Excellent. Where can people find you if they want to get in touch with you, they have questions, or they want to learn more about resilient healthcare?
I am best by LinkedIn.
Okay. Perfect. And they could just look under your name. And also, regardless of where you're listening, in the show notes, we'll have a link to Jackleen's LinkedIn. Tongue twister. And what's the website?
Resilienthc.com.
Perfect. All right. So before we finish, I'll ask you the same question I ask everyone. And that is, knowing where you are now in your life and your career, what advice would you give to your 20-year-old self? I'm assuming maybe just entering PT school around that time. Roughly.
I'm just kidding. Yeah, 20 years old, I was entering PT school, and I would advise myself, play on words here, but to be resilient and to continue pushing forward, because there's always a way around or through whatever challenge you're going to have, whether it's a startup challenge, private practice challenge, family challenge, a way around or through, but there's always a way to the other side.
Perfect. I think that's great advice. And Jackleen, thank you so much for coming on. I always love talking to a fellow PT. So thank you so much for your time and all of the great info you shared.
Thanks for having me, Karen.
Of course. And everyone, again, resilienthc.com if you want to learn more about resilient healthcare. Thanks so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.